Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm Hospice Nurse Penny.
And I'm Halley, hospice social worker. Today we're going to bring back a favorite.
Our favorite. We are
Andrew.
bringing back Andrew White,
The
Planty-Murse. We are bringing him back because last time we had him on, we were fangirling so hard that we really failed to discuss with him what we intended on discussing, which was death in the ICU. So we are going to stay on topic as much as possible. Try not to fangirl.
Yes.
Although I don't know if we can get away with not asking him about his new series in the break room.
I'm asking.
We love Andrew, and we are so excited to have him on today, not only because he's just really, really funny and smart, but he is going to be able to provide us with some great insight into death in the ICU.
And speaking of that, I thought we might want to start out our education piece by talking about why it's so important to have advanced directives / at least the conversation, as you point out. Just have the talk with the people that are going to be your decision makers before you end up in the ICU.
Yes, yeah. So I think what happens sometimes when those discussions haven't taken place, even if there's advanced directives that are written out, I think there can still be some confusion about what they really want. Well, they said this, but they didn't know this was going to happen, and now they're in this position, and what do we do about it?
Yeah.
I think a good example of that is when somebody has a stroke and they might recover. Do we tube feed them in the meantime? What do we do? So having that conversation is vitally important, because I think what people do when they don't know what their person would want is they're going to do for them what they would want for themselves. I think it's human nature for us to think, well, I think this is what I would want, and so that's probably what they would want.
Or they're going to err on the side of medical interventions, kind of like the standard for all care if you end up in the hospital is you're going to err on the side of trying to save life or prolong life.
Yes, absolutely. That's it's always going to be, that's what doctors are trained to do. And,
right.
And hospitals don't want to have any deaths on their statistics too. So that's kind of a factor as well.
Oh my gosh, we were just talking about statistics now. I'll leave that soapbox for another conversation, but yes, I think it's just so important to just start talking about it. Nobody wants to think about or talk about death. I get it, but that's why we're having these conversations, is because you never know when you're going to end up in the ICU. It's not like hospice where you probably see it coming, at least for a little bit. And
right.
You're not going to have time to have valuable conversations that are going to help your loved ones. You're giving them a gift by letting them know what you want.
Absolutely. You really are. You're removing a lot of the burden of guilt that people can have when they are making those decisions. One of the things that I've said often is that it is much more difficult to make a decision to stop tube feeding once it's started than it is to not put it in the first place.
Yeah.
Because when somebody is critically ill to the point where they're saying they're going to need tube feeding, they're really close to whatever disease has occurred or whatever medical thing has happened to them. And so it's you can see, like, if you don't put the tube in, they're not starving to death. They're really dying from their disease. But when you put that tube in and you get further and further away from that event that happened, it's really more like taking the tube out, you're actually causing that person's death. So I think, it's easier to say no in the first place. So really, again, helping to alleviate any guilt that a person may have for making those decisions by telling them what you want. And, Halley, I just made a video yesterday talking about what happens if you are married, but you're separated, you're estranged from your husband, or you're divorced, but you haven't put any advanced directives into place, or you haven't changed your So if you haven't put advanced directives into place and you're estranged, then your spouse maybe the person that's going to make your decisions for you.
Mm-hmm.
If you're divorced, but you had advance directives in place that designated your spouse and you haven't changed that, then your ex-spouse is going to make decisions for you. So you could be in the position of having somebody you don't like, who doesn't like you, making a decision about pulling a plug or keeping it going.
Yeah, it's the big D's we talk about, right? Make sure you update them on every decade, after a divorce, after a big diagnosis or new disease. That's going to be important.
I have never heard the big D's. I like that.
Yeah.
It's the 3 Ds, like the 3 Ps that we do in nursing: poop, pain, and pill. Poop, pain, and pee. Poop, pain, and pee.
Yeah, I think there's supposed to be 5 Ds, but I can't remember the fifth one right now. So
yeah, it makes sense because, like in our state, I know, and state laws vary, of course. So you always want to look at your state law because, there's going to be differences in state law. But in our state, the hierarchy is if you're married, it's your spouse that makes those decisions. So it doesn't matter if you're separated, they're going to make those decisions for you. So make sure that you are choosing wisely.
Choosing wisely and having the conversation so people know.
It's literally a matter of life or death. Literally. Mm-hmm.
All right, let's get to Andrew.
All right, let's do it.
Welcome back, Andrew.
Thank you for having me back. It's great to be here.
I mean, you are a fan favorite. I'm pretty sure we're going to have to find a way to bring you back every season now.
Yes, definitely. You're our favorite, that's for sure.
That's nice. I'm game. Yeah, I'll come back.
All right. So as you know, last season, we were supposed to talk about the ICU and death and dying.
Yes.
Clearly, we completely lost our way and fangirled out about your social media accounts. So let's just get that out of the way right out the gate, because now you've started something new we have to love, which is Meanwhile in the Break Room.
Yes.
So tell us a little bit about Meanwhile in the Break Room, how this came from what you were doing, which was still some skits and education, but now focusing on the break room.
You sure you want to start with this? Because we're going to go down a rabbit hole.
I know. I think we need to start. Let's get the business over first. Let's get business out of the way.
All right. That's fair.
Okay. So,
go ahead.
We want to talk about death in the ICU, what that looks like.
Yes.
And then we also want you to talk about your CPR video, because that was really very, very powerful.
Yes. Yes. So really, I want to know, what does end of life look like in the ICU from your perspective? And how is that handled? Because that's very different than what we're doing in hospice.
Right. I think in the ICU, you have really two types of people that are dying. You have those who have been chronically ill for a while, and it's kind of expected. They're reaching the end of their life, and coming to the hospital was kind of a last-ditch effort to see if we can get them through one more time. And then you have those who suddenly die. It's just sudden. They were living their life, and then a tragic event happens. And both of those, while the dying kind of looks the same, the family's reaction to each one is entirely different.
Mm-hmm.
I think the people who die from chronic issues, who have been sick for a long time, that probably looks very similar to what you two experience in hospice.
When you say what it looks like for somebody who's chronically ill, are you referring to what the dynamic with the family looks like, or are you actually talking about literally what the dying person looks like? Because one of the things I'm curious about is, what does the dying process look like in the ICU? Because in hospice, we see people go through this dying process where they eat less, they sleep more, they're introverted, then they start having these physical changes as well. They have visioning, deathbed visions, they talk in metaphors. So what does the physical death look like in the ICU?
I think what you just spoke about, where people are eating less, they're kind of shutting down, that's not often seen even in chronically ill people in the ICU, because by the time they're at that point, we kind of ship them out to the regular floor. The ICU is for people who have acute issues, and we're trying to actually save a life. People in that sense, up until the point where we decide, okay, we're going on comfort care, we're going to be dying, they're on a ventilator. We're trying to save them. And there's really this point where there's a decision-making process happening. You either have to get a tracheostomy and live your life in a nursing home, or you take the ventilator off and decide we're going to let nature take its course. And
For folks that don't know what a tracheostomy is?
Yeah, tracheostomy. So ventilator is, we all kind of seen that, probably someone in our family. There's a tube in your mouth that's helping you breathe. You're usually asleep or unconscious. A tracheostomy is after, I'd say, 10 to 14 days, the tissues in the throat start to break down and it becomes uncomfortable for the patient. So they talk about cutting a hole in the throat, in the neck, and putting the tube through there to continue ventilating that patient.
But people are awake after this?
After this, people are potentially awake. If they go on to a nursing home and they're able to be awake without fighting the ventilator, the machine, then they can be awake. Tracheostomies can be reversed. You've seen people maybe who have scars on their neck who used to have a tracheostomy and it was reversed. But for the most part, people with a tracheostomy are on it for the rest of their life. And that's really the point when family members usually decide, would we want our loved one to be on a tracheostomy, or are we going to change course and think about comfort?
Andrew, when someone is intubated, I have always thought that they are going to be sedated, like with Versed or whatever, because people will naturally want to pull that tube out of their mouth. But then during COVID, I remember there were some nurses talking about patients being awake and intubated.
With COVID, I didn't see too many people awake and intubated. In fact, with COVID, they were more sedated than normal because the lungs became very much like scar tissue, and it became more difficult to use the machine to breathe for them because the lungs weren't as elastic. And so a person who was awake with COVID with the scar lungs, it was just increasingly uncomfortable for them, more so than if they didn't have COVID. And so often with those patients, we had to paralyze them, not only sedate them, but paralyze them so their body just didn't move at all. But to your point, there are people who can be intubated and awake. I'm thinking more of people who maybe they had an allergic reaction and their throat is swollen. Because they're not having a lung issue, they have a breathing tube in there just because their throat was closed up otherwise. And they can be awake, and they're usually only intubated for a day or two until the Benadryl works and the epinephrine works and the swelling goes away.
Is that awful? Like, it seems like that would be just awful. I've had surgery where they intubated me, and then as you're coming out of it, they pull the tube, and it's just awful having it in there.
Sounds like my worst nightmare.
Do you remember
What's that?
Did you remember?
Yeah. Oh yeah, I remember it. As I'm coming out of the sedation, they're pulling the tube, and I can feel it coming out. Yeah.
Oh,
it's
I would say
awful.
if I had to predict numbers, I would say 98% of people are asleep the whole time that they're intubated because it's just more comfortable that way.
Asleep or maybe dying too, right? If somebody's intubated, it could be because they are close to the end of their life and they may be actually just unresponsive because they're dying.
That is true. And you can be intubated at the end of your life because both your lungs are sick and you just can't breathe without the machine, or something else is happening, like your heart or your kidneys are bad, and the amount of medical therapy that we have to do to your body is so uncomfortable that we also just intubate you so you sleep through it and nothing is wrong with your lungs. So both of those things can happen.
When you have somebody on comfort care in the ICU, are you all liberal with the opioids and benzos to medicate for comfort? Like we're we say we're liberal. We use them liberally, but we use them, of course, in reasonable doses that don't end people's lives. But
Right.
I mean, are you good at pain management in the ICU?
We are, absolutely. And I'm going to just kind of see if you're the same here, Penny, but even if people look comfortable and asleep, I will still medicate them because I don't know underneath that, are they quietly uncomfortable, if that
Mm-hmm.
makes sense. So yes, I always think about what I would want. If I were dying, I would want to be as comfortable as possible. And that's always an educational point too with the families, because oftentimes families think that the drug is what kills their loved one, and we know that that's not
Right.
true. It's the dying process because of whatever they have, their disease process is killing them, and the medicine just makes them more comfortable. But
Well, and also when you're giving medicine for pain and it's working, you don't want to stop because it's going to stop working.
yeah,
So it makes sense to keep it going. We do teach families how to assess for pain in a person who's unresponsive by usually looking at the forehead, because the forehead can be very creased up when somebody's uncomfortable, or guarding, stiffness, ouching with movement, that type of thing. But definitely when somebody has started pain meds, and we encourage people to continue the pain meds because they will have pain if you stop giving it to them.
that's true. I also feel, and I have felt myself, and I know that this is not true in my mind, but I have felt that the pain medicine has maybe made them go faster. I know that that's not true. I know the literature doesn't support that. I know that the literature actually supports the fact that if you give pain medicine, they may live longer because their body kind of settles and isn't fighting so hard. But the timing of giving pain medicine to when the person actually dies sometimes feels, I don't know what the word for it is, feels suspicious.
Suspicious.
Does.
I mean, I have different. So for me, I think I will sometimes say that morphine doesn't cause death, but it facilitates death, because if somebody is really uncomfortable, they are unable to calm down and be peaceful enough to let go and die. I've seen that so many times. To
Yes.
your point, also, they may be comfortable and they might linger. Now that they're finally comfortable and relaxed,
Right.
they can linger for a while. So I think it goes either way. I think it can facilitate the death, but not cause the death. And especially, people think we overdose patients in hospice, little old ladies who can't tolerate morphine, they're opioid naive. We start people at 5 milligrams of morphine, which is actually lower, dose for dose. It's lower than a Percocet, because oxycodone is like, I think 1.5 times stronger than morphine. So people don't understand that morphine is not a stronger drug, and we're only giving a very small amount to people who are opioid naive. But when we see people going through a dying process, and it's normal for them to sleep more and more because that's part of the process.
Right.
And then as they get closer to the end of life, they may have a spike in symptoms that we need to manage. We give them medication, they're sleeping more and more. And people think, oh, I gave the morphine, and as soon as I gave it, they never woke up again. Well, sedation is a side effect of morphine, but it's a side effect that people will adjust to. If they're not waking up, it's not because of the morphine, it's because they're dying. So we kind of,
Right.
have to really talk people down off the ledge. And do you have to do that? And so, like, I can imagine if you have a patient who's had a traumatic, unexpected injury and they end up in the ICU, that is going to be a much more challenging situation as far as family dynamics and decision making than it is if they are chronically ill. Is that what you would say
I would
most of the
say
time?
yes, and it just kind of goes back to education. People with an acute injury, a heart attack from out of nowhere, a stroke from out of nowhere, of course, the first week is save them, fight. That's obvious. But when
Mm-hmm.
you start pulling in things like their brain is never going to be the same. Their personality is never going to be the same. Once that kind of sinks in, the decision to let someone be comfortable and take away the life support becomes a little bit easier. I think you probably thought I was going to say something different, but I think the people with acute injuries who you see that there's probably going to be no hope, those families are actually easier to get them to accept that this is happening, in my opinion. Because the people with chronic illnesses, the family's been just fighting for so long, for years, and they always come back and they say, well, she's such a fighter. She's always fought this. She's always gotten better before. And it's harder to get them to understand this is the fight that she's going to lose. Whereas in the other situation, we've done all we can. This is where we are. So
that wasn't what I expected, but as you explain it, it makes perfect sense, because that is what I've seen with hospice patients. And I've had patients who came to us with a very short diagnosis, and those who fought it for ever, and the family just, oh, they'll make it through. They always make it through, you know. So yeah, it really makes perfect sense. So you made a video on TikTok that was just mind-blowing. It was just such an excellent video about CPR, what that looks like. It was so educational, and I think it ended up, I want to say that I might have duetted it and it got a warning on it, or it's got a warning on it on your page, right? Like,
right.
What do they call that warning?
Viewer
sensitive content?
Sensitive content, something like that. Yeah.
Yes.
So when you made that video, what prompted that? Had you had a recent experience, or just a culmination of those experiences, or just felt like that was just something you wanted to educate about? What prompted that?
I'm not sure if there was a specific incident that week that prompted that. You know, I always have a list of 50 different things I want to talk about on TikTok. And as I was looking through that week, I thought this is actually something that I've been wanting to do for a while. And I just did it. And for those of you who didn't see the video, it was kind of just a graphic narration of what happens during CPR in an ICU hospital. And I didn't pull any punches. I talked about the fluids and what the body looks like, and all the things that happen.
Why don't you, can you walk us through that?
Sure. So how does it start? So the heart stops, or the person stops breathing. A bunch of people rush in the room, more people than are probably necessary to be there in the first place. The person's clothes are removed from their body, so they're naked, but you have to do that because you have to attach pads to their body in case you need to shock their heart. And so that's happening. And then at the same time, someone is on top of them doing CPR. And I think one of the most shocking things about that video that I got comment over and over again was that I was talking about how violent the CPR looks. You have to push down 2 inches into the chest to be effective. And you never see them do that on a TV show. That's just not a show. When you can't do that on a TV show because that's an actor sitting there. You can't push 2 inches into the actor's chest. That would hurt them. But that's what you need to do. The body is bouncing up and down as you're doing this. I have every healthcare worker who has done CPR will tell you can feel ribs breaking as you do it. If the person has any sort of internal bleeding or mucus, or they were vomiting, whatever, all the fluids come out of their mouth and their nose when this is happening. They lose control of their bladder, sometimes more. If you have to shock the person, it's kind of a violent jolt. People are screaming and talking. We try to get the families in there if possible, because we need them to see that we're doing everything for their loved one. Very difficult for them to watch. And that's,
I was not expecting you to say that part. I thought you would have had them out while the chaos was going around, but that makes sense to have them witness it.
I want them to witness it. We all want them to witness it because, number one, it's important for them to know that we're doing everything possible. And number two, in most cases, CPR does not bring them back to life. They die. So
Right.
this is your last chance to be with them while they're alive, even though it's horrendous. That is your last chance to be with them.
I think what
I love
people
that.
don't understand is that CPR is done on a person who's clinically dead, right?
Yeah.
They have no heartbeat, no respiration. My social worker I worked with in hospice was really good about explaining that to families when we talked about their code status. If you are found down without a breath and without a heartbeat, do you want us to try to bring you back by initiating CPR, or do you want to allow a natural death and let your body just do what it's going to do and go? And she
Right.
was really, really good at that. I think your video should be shown to every family member in every ICU medical clinics, like not even just the ICU, but like people should really be able to see that video. I mean, the way you explain it is incredible. I mean, you go beyond just the fractured ribs, which is what I've done a few videos too, demonstrating
Sure.
like what it's like. And then I'll have people in my comments saying, "No, it's not true. The ribs don't break." And I say, well, then you're not doing it effectively because you need to go into the chest, like you said, 2 inches, but like the spewing of the fluids from the mouth and the ripping off the clothes and baring their boobs if they're women,
Yeah.
it's like, it's undignified. And even if it's not painful or traumatic for the person because they're dead, it's traumatic for the people that are initiating the CPR, continuing it, and the
Right.
family who's watching their person do that,
And even if they die, which is most of the time,
Mm-hmm. Mm-hmm.
this is their last moment. This is their last moment on earth being pummeled, assaulted.
Yeah.
You're surrounded by strangers you don't know,
Mm-hmm.
just ganging up on your body like that. That's terrible. And one of the takeaways was, for me, excuse me, one of the takeaways was, even if we get you back, even if you come back, the reason that your heart stopped in the first place is still there.
Yes.
Did it stop because of cancer? Did it stop because of this other disease? We didn't cure any of that. We just restarted your heart, and it could stop again easily because the reason it stopped is still there in your body. Excuse me.
Right. Yeah, that's what I would say to patients too, is even if we get you back and you're in that very low percentage of people who can be revived with CPR, you're still going to be dying. You are still dying from your disease. I think CPR, I think it's like 15% of people that receive CPR that can actually have life restored. And it is people who mostly have had some kind of a traumatic injury, a drowning, or I know that, what's his name? The Friends actor, Matthew Perry,
Yes.
had CPR done on him after a drug overdose, and he survived, and he had fractured ribs after, which he said was horrible. It was painful. It took a long time for them to heal. So yeah, I think when somebody has a disease, a terminal illness or a chronic disease, and they essentially die and CPR is done on them, it's even a lower percentage of people that can probably be brought back. And in the case of drownings, you're not necessarily restoring life in any semblance of what it was prior to that injury. And
Right.
I had done some clinical experience there's some houses here called Ashley House. They're medical facilities for children with chronic or terminal conditions. And there were several kids who had drowned and were restored. And one of them was, I remember, very vegetative, had just really no quality of life. I mean, he was alive, but he was not living. And I remember that one of the people that worked at the Ashley house said that the firefighter that rescued him had said he wished he never would have done CPR on him because he brought him back to no life, you know?
Right. I mean, it's terrible because that's your instinct to try to save someone. That's your instinct. But really, think of CPR like being in a car crash where you get injured, terribly injured. Only people who are relatively bodily healthy can come back from that. If you're already at the end of your life, you're a frail person, even if you're not frail, but you have, sometimes you look at someone's chart and you just have to use that little roller clamp on the mouse and you keep going down, down, down at all their comorbidities, and it just like 3 pages. These are not people who you should be doing CPR on.
Right. And have you had to do CPR on those people?
Oh, yes. Yes.
Yeah.
Because the instinct for most family members is, please just save them.
Yeah, save them. Do everything.
But
often... Go ahead.
Oh, but I have had people, that's another reason you bring them into the room too, because they see what's happening. The family members, they see what's happening to their loved one. I've had a lot of instances where the family says, okay, please just stop, because this is too much.
Can you stop I know, Halley, you got a question too, but I just had one that popped in my brain. Let's say there's a family member that's visiting, but there is somebody else who is the legal POA. Right. Can you stop if maybe the one daughter comes in, but she's not the one that has the medical decision-making permission legally? Can she say, stop, will you honor that? Or do you have to keep on going until you can reach the POA to say stop?
Yeah, no, we have to keep on going.
No.
Yeah.
Halley, go ahead.
You sure?
Yeah.
I was going to ask about advanced directives. So it's a good segue. I'm just thinking how many people, anecdotally, I don't expect you to have an exact figure, would you say of people coming in, even with chronic illnesses, that have advanced directives and or their loved ones actually know what they want? Would you say that's more often or not as often?
Not as often. I would say people with written advanced directives that you can actually get a copy of and put on the chart, probably 10% or less.
And that's why this conversation is so important.
It's terrible.
That's terrible. And that should be a requirement.
It should be, but it's just sadly the honest truth. And then your question, how many family members actually know what their loved one wants? Maybe 50%. A lot of family members live across the country. They don't live, you're calling someone from New York to come to California because their mom is dying and, they don't know. They don't know.
Oh, that's something that we experience a lot too, that the last time they saw Aunt Jean at the family reunion 6 months ago, she looked fantastic. What do you mean she's dying now?
But I will say, I will say this though, if there's no advance directive and we have established that you're the next of kin, you're the legal, the spouse or the daughter, whatever, whoever you are, you're the next you're the next of kin for sure. We'll do whatever you say. We don't need paperwork in place.
Right. Same. In fact, I mean, for us, I don't know, Halley, if this is your experience, but my experience is when we are never able to get a confirmed DNR out of a patient, they're implicitly a full code, right? If you don't have a DNR, they're a full code.
Yes.
So when they die, the family just chooses not to call 911. They just don't.
Oh, okay.
So that happens. Like, we want our patients to have a pulse, which is that kind of advanced directive for hospice patients, or not hospice. Don't have to be a hospice patient to have a pulse, but we want them to say, yes, I'm a DNR or I'm a full code. We don't really want them to say that, but they do. But if they don't ever commit to DNR and the family just doesn't want to go there, I've had families take me aside and go, psst, psst, psst. Just don't. They just are like, they don't want to talk about it. That there's a generation of people who think that you can actually make them live longer and bring them back from anything.
I'm very curious about the ones who do have a DNR and the family calls 911 anyway. Is
So
911, if you call 911, is that consenting to CPR? They come in, then they're required to do CPR?
if there's no written directive, then yes. So even if the patient says, I'm a DNR, they fill out a pulse, they've got it legally signed, it's there, but there's a family member who says, I want to do everything, they call 911, they will.
Your
You can
POA can override
override.
it.
Yes.
Mm-hmm.
You don't have to be a POA. Any family member can override it. But if the POA is there and says, no, don't do it. And here's some EMTs are going to want to see the paperwork before they don't do it.
Well,
So if you're not the POA and you just take the little pulse and stick it in your pocket and call 911, say do everything.
Jeez.
Yeah. The EMTs will err on the side of life for sure. They don't want to be sued. Nobody wants to be sued.
Of course. Yes.
All right. So is there anything else you want to tell us? Because, we want to switch to a more lighthearted, fun topic. Is there anything you think people need to know about, we already kind of talked about advanced directives. And
I think the last thing we were talking about is probably the most important. Know what you want. Make sure people around you know what you want. And if the people around you do not agree with you, find a family member who does agree with you and make them your power of attorney.
Yeah. Yes, absolutely. Thank you for that. And put your wishes in writing too.
Absolutely. Yes.
Yeah.
Well, before we go into the fun topic, I do just want to wrap this up with a little bit of self-care, because I imagine there's certain patients, just like with hospice, that touch you a little more than all of them. This work is hard. And so what do you and other nurses do to get through this kind of challenging work?
Everybody has their different way of doing it, so I can't tell you blanket what we all do. I know that just taking time off. Mental health.
Is that what you do? What do you do? You make videos. You make TikToks.
Yeah, but I also take mental health days too. I know exactly what my sick policy is at work, and I use it right up to the line.
Mental health days are important. I have taken mental health days when I had a patient who was dying and they didn't die. And I was not I went through the whole weekend thinking I told him goodbye already. I got him to change his code status from full code to DNR. He was safely ensconced in a beautiful care center, receiving wonderful care. I knew he was going to die, and then he didn't. And I was like, fuck that. I am not going to go see that man again. I am taking a mental health day. Then he did die, thank God, before I went back to work. So
I think also it's important to be in a good text group with like-minded people, and you can just go crazy in the texting comments back and forth. That's very therapeutic for me.
Support is good.
Yeah, definitely. Dark humor is my jam for self-care.
For sure.
Yeah.
I love mental health days, but it's important to schedule time off too. I have started doing that ahead of time, like just scheduling myself one long weekend a month or something, like whatever works for yourself, to have the time, the mental health days, to be able to take off in the moment, but also scheduling. I love that as generations are progressing, we're not afraid to use our vacation days that we freaking earned.
Right.
Yeah.
It's not
and
this
saying
big
no,
status.
and
feeling
empowered to say no when you get called in over and over and over to try to on your day off. Especially.
I think that comes with age, and I'm of the age where I'm a no person for sure.
Yeah. Thank you. No, thank you. I don't need the money anymore. That's one thing when you're young and you need the money. All right. So
transitioning, and I want to know, your bio says hospital management. Were you ever a Janina?
A Janina. I think we've all been a Janina at some point. It depends on what the context is, but I've written people up. They deserved it, but that person probably thought I was a Janina. I'm sure we've all had Janina moments in our lives.
All right. So what we're talking about for those listeners or watchers on YouTube who don't know what we're talking about, Andrew started a series on his social media. It's called In the Break Room, right? In the Break Room?
Meanwhile
in the break room. And it is a number of incredible characters in a nursing break room, in a hospital,
an ICU, right?
in an ICU.
Yes.
And hilariously funny. Definitely off the beaten trail sometimes. I mean, I love it. And the characters are hilarious. And it's like watching it, it's hard to believe that's really you in all of those characters. And your new characters that are coming in, they're just like better and better. So I love the one who puts the hair in front of her mouth all the time.
Oh, yes. That's Ione.
Ione. I love her. And I really love, and I've only seen him one time, the newest one, the dad vibe dude.
Oh, Brett. Yes.
Brett. Oh my God. Where do you get these inspirations? Like, how do you do this? It's
Well,
genius. I mean, it's literally genius.
many of them are based off of characters at work, both present and past. And like there's always these types. We've all worked with them. There's the older one who's been there forever. There's the young one who's kind of lackadaisical. So I started with just a few characters that I used over and over. But as I created this world and realized that I have something here. This is not only exciting to me, but people are responding to it. I recognized that I needed to just, the more characters you have, the more you can play with them back and forth and create these storylines. So I don't know where I come from. I don't know where I get it from.
Oh, okay. I have questions.
Yes.
All right. So do the people you work with watch your series, and those who you have based characters on, do they recognize themselves? And if so, is that like a slippery slope for you? Because you got to be careful that you're not insulting them with your portrayal of them.
So there's only one character, aside from myself. I play myself. The Andrew character is pretty close to how I would be in real life if you met me. The only character who's actually based on a real person and is taken from real life, that is Candace. She's a charge nurse. She's got a little necklace and she wears the white cap on her head. When I was in management at my last job, in the story, Andrew and Candace are both the charge nurses now. They work together. They're like assistant managers. And this woman, Melissa, and I were assistant managers at my last job. And so she passed away recently, and this character is kind of my everybody loved her. She was in the Navy. She was very strict. They often played us against each other, mom against dad, because I was more like, yeah, whatever. And she was by the book, and they would go over her head and try to get me to do something for them. But she was also very beloved, and that is the only character that is drawn from real life. Everyone else thinks that they are characters. I have a very good friend who is very similar to Sam. I have a very good friend who's very similar to Ginny. Who else? Ione is based on someone that we know, but it's also not 100% them. It is pieces of them, and then I add histories and backstories that have really nothing to do with the people that they are similar to.
What kind of feedback do you get from your coworkers who watch it?
They all like it. They all love it.
Yeah,
they watch it.
Of course they do. Of course they do. Who wouldn't?
Sometimes I'll have an episode or two that I haven't shared yet on social media, and they get sneak previews, and they're very excited for the sneak previews that I give them.
Oh, well, I want to be in on that.
I mean, you kind of already were, Penny.
Yeah.
Well, yeah. I want to do that again, too. So that was fun. I can do better. I was watching Dr. Beach Jam. That's what I call Dr. Beach Jam.
Yes.
And I was like, damn, she was so good. I want to do better next time. I felt like I want to be like more interactive.
Yeah.
Although I did make bloopers, so I'm still waiting for a blooper reel.
I need to bring you back for sure. I have another cameo coming up in the next few weeks. I don't know if you guys watch you've probably seen her stuff. Do you know who Ashley Vortman is? She
The name
creates,
sounds familiar.
she makes crafts, kooky crafts. Like she'll take a teapot and she'll
Oh,
crack it.
yes. Peculiarly Ashley, right?
Yes.
I
Yeah.
love her.
Yeah. So she's coming on. She's going to be Reagan's mom.
That's
she's
fucking
gonna
amazing.
And because she's, Reagan's crafty and she crochets and she paints and all this kind of stuff. And so that's her mom. So we're going to bring her in. But yes, then after that one, I'll probably, Penny, ask you to come back. Maybe we could plug your book. Let's see.
Oh, yeah.
That'd be
Yeah,
cool.
that'd be cool.
Yeah.
Yeah, that would be great. Hey, how your kids are kind of still pretty young, right? They're like 7 and 9 or.
They're 15, 12, and 9.
Oh, okay. So who of your family members watch your videos? Does your wife watch? Do your kids watch?
So my mother probably watches the most religiously. My wife just got on social media. She was always very just like, oh, that's kind of cute. And then, we go off and do our own read a book. Like, you're married for someone for 20 years. You're like, oh, okay, that's real funny,
Yeah.
But now she does watch my stuff. The kids, sometimes they ask to watch it, but it's not necessarily content for kids. So I don't really show them unless it's something with no cursing. Maybe I'll show them every once in a while, but that was, now it's these characters that they don't know. They don't care about that. The earlier stuff, the stuff before this show, when it was like a one-off sort of a topic, was more appealing to them, I think.
Yeah, I think probably working in healthcare, that's going to be your biggest audience grab. Although I could see people liking it even if they didn't work in healthcare, because the characters are so dynamic and
relatable.
I mean, relatable and realistic. I watch them and it's like, I literally feel like these are different people. You're so good at it. It's so good.
I get a lot of comments for people saying, I don't work in healthcare, but I'm addicted to this show. Because I'm trying to make a mini soap opera. So,
and you are, and also you just started doing the erstwhile, talking about the characters, and it's just so professionally edited. And I love the little interaction, like at the end with the character and with you, who's doing the, talking about the development of the character. And I see the promos for the next one coming up, and I'm just like, all right, I gotta watch that one. Like I literally, it's like a show. It's like something that I'm addicted to watching. And there's been really nothing on social media that I feel that way about. Honestly, I mean, I like Call Me Chris and I'll go watch your videos sometimes, but I don't have the alert on so that I can, are you on YouTube with this?
Yes.
The break room. Okay. So then I need to put the alert on for that because I can make sure that I don't miss them. But, honestly, I mean, I'm not just blowing smoke up your ass and fangirling, because you're going to be famous and you've been on our podcast twice now. And I was a guest on your show. I literally mean that, that's the only thing on social media where I'm just like, I got to see the next one. I got to watch the next one that comes out.
Yeah, I made that inspired because I'm at 20 or 21 characters now, and that's a lot. Especially if you don't watch every episode, you're like, who is this bitch coming on here? So that's why I made the erstwhile thing. Hopefully, I'll make one for each character so you can refer back if you need to understand where we are.
I really appreciate that, because you're right. Some of them are like, whoa, wait, which character? And I love that you bring in CNAs. I know Penny and I have talked about how important our CNAs are. So it's not just nurses, that you're bringing in other disciplines into there. And
you need a social worker. You haven't had a social worker yet.
I know. I have to bring in a social worker. I have to bring in a pharmacist. I have to bring in PT and OT.
We know what pharmacist not to bring in.
Which one?
You know the one.
Do I?
The one that said she knows all about bedside things.
Oh, yeah. The hospice pharmacist who was... Oh, yeah. That's right. Okay, yeah, don't bring her in.
I'm not going to say a name.
No.
Yeah.
No. You bring in Savannah, our exorcist.
Okay. I have to slow down because it's getting, the universe is getting bigger and I'm getting more comments like, it's too much almost. So I have to meticulously bring in people slowly, and thoughtfully. So, but I'm building a world. You need a lot of characters.
Yes, you do need a lot of characters. I
we're
think
at the beginning. Yeah.
there should be like you can make playlists too on TikTok.
Yeah, it's in a playlist.
You can create playlists, and then there should be a way to like better catalog them all. So you could be like, people can like seasons, season 1,
Yes.
and then the behind the scenes and the erstwhiles and the blooper reels and
Are your episodes numbered so people can watch them in order?
They are. If you go to TikTok, I have a playlist, and it just plays from number 1 down.
Perfect.
And then if you go to either YouTube or Instagram, if you look at the titles, they all have titles. And
okay, good.
Episode numbers too, so you can. I just wrote episode 31 today. So
wow!
We're getting up there.
Wow, 31 episodes already.
Yeah.
Wow.
I appreciate the timing of the release because it always seems to coincide right when I'm getting up, getting ready, and I go to check and like, bam, you're the first. The algorithm brings you to me. I don't have to search you out.
Yeah. Thank God there's analytics on your videos. You can see when your followers are on TikTok and when they probably are at work and they're not on TikTok. And then, so.
I don't find the analytics on TikTok to be helpful. I've tried posting and they've changed a lot too. And Hospice Nurse Julie and I were talking about hers were like in the middle of the night recently. They were like 2 a.m. And I don't like, I've tried posting when the analytics show that there's more of my followers online, and it doesn't seem to matter. It's really weird. I have been paying more attention though, like on Instagram to do that.
I don't think there's a right answer. I don't think we'll ever know.
Yeah, it's true. We'll never know. But
I think we got you in a much better place than last time we talked to you. Last time was right in the middle of all that chaos and getting a lot of hate feedback. And so I'm glad to see are you feeling like you're in a better place?
Yeah, although I did get a couple of hate comments on that video from 100 years ago. I just made that video available to only friends now. So you can still watch it, but the general public, I can't anymore.
Yeah, it's really interesting how videos will go back through circulation and you'll get more hate and more hate. And it happens a lot to me too, where I'll get one that went viral. And part of the reason was because there was a lot of hate, and then it goes back through. And I feel like responding to these people and saying, that's fucking old news, man. That video is out 2 years ago. Why are you still hating on it? But then I get in trouble for saying things like, you're a useless skin bag.
I'm just glad it didn't discourage you from continuing on.
Yeah, I'm definitely excited about this new content, and maybe a little obsessed. So it'll be
are we all
for a while.
Yes. Yeah, we are obsessed for sure.
Yeah.
Oh, Andrew. Well, as usual, we could talk to you all day long, but I want to be honoring of your time, especially because, like I said, you're just going to be an every season guest. That's just going to have to be how it is.
All right. Sounds great.
So, is there anything else you would like to tell us?
Oh, and we have one more question.
Yeah.
We've just been adding this into season 2. So our new...
Oh, that's right. Our new question. A coffin question.
What would you like to happen to your body when you die?
Oh, I would like to be cremated. I've heard of this thing called water cremation.
Mm-hmm.
I want to do that.
Okay.
Aquamation.
Yeah.
Have you told your wife this?
I have told her that. Well, we both know we want to be cremated. So we're like, I have a wife who's like on the same page as me as for almost everything in life. So we both want to be cremated. I don't know if she would know to do the water. What is it called? Aquamation.
Aquamation.
I don't even know if they have it in my state, but that's just environmental, because I like environmental stuff. So that sounds great.
Well, I'm going to be body composted. Yes.
Yeah, I'm going to be body composted. That's my plan.
Nice.
And I think it's legal. I don't know if it's in Idaho yet, but yeah, I'm the same way. I care about the environment. So I don't want, because cremation used to be the thing. And now it's like, it's not as good for the environment either, but I definitely don't want to be taking up a land space by being buried. So
Yeah. Plus, it's a fast process, and then I guess the ashes are more silky, powdery, easier to
with
disperse.
aquamation.
Yeah.
Yes.
Mhm.
Yeah.
So, yeah. Perfect.
Yeah. All right. Well, tell everybody where to find you so that they can go watch your amazing sitcom. I call it a sitcom.
So you can find me on TikTok is my biggest following, but I also post to Instagram and YouTube. My name is Andrew White. If you just put in my name, you'll probably find me. My handle is called Planty Murse, not nurse with an N, but Murse with an M, PLANTYMURSE, because I'm a male nurse who is a vegan. That's why I'm a Planty Murse.
And if you want to hear about the vegan part, go back and listen to season 1.
Yeah.
Yeah, please come check me out.
Yes, definitely. You won't be sorry. Thank you so much for
Thank you, Andrew.
coming back, Andrew.
Absolutely. All right. Thanks. It was nice seeing both of you again.
You too.
Oh, Andrew, our favorite.
Andrew. Our favorite. And like I said, literally not blowing smoke up his ass when I tell him that he is the only person on social media who I am going and looking for now to see his videos. And I love the turn that he's taken, but I also still really appreciate all of the educational videos that he did on that CPR video, especially.
For sure.
Really, really like that one. And I hope he pins that, because I think it'd be great for people to go and see that video if they don't really understand what it means to do CPR on a person. It's violent and brutal and horrible, and it rarely works.
Well, and hopefully, like Sammy is hoping for, and Cian is hoping for, and we are hoping for, is really to normalize this conversation way upstream so that people can't have these conversations and make decisions for themselves and their loved ones before it comes to that. There is a time and place for CPR. We're not saying that at all. But in circumstances where it's end of life, why would you traumatize the body like that? Why would that be your last memory of your loved one?
Absolutely. Yeah. Horrible. And the last thing that they experience, that brutality and just indignant process. It's just horrible and
not
painful.
For me.
Not for me.
I already have my advanced directive set for that. So we'll see if they get honored.
If I was in a car accident, if some kind of accidental thing happened to me and there was a good chance that they could bring me back, then do everything, But if I'm terminally ill, or chronically ill with something that will eventually end my life, then no, I don't want it. I don't want it. So
exactly.
But yeah, that was a great interview. Just love Andrew. He's so amazing.
As always.
Yeah.
Well, until next time, remember to live. Because
someday we will all be dead. And if you're like us and you are no codes, you'll stay that way.
Bye.
Bye.